I want to start by giving a big thanks to the meeting organizers and especially to the Stephen and Alexandra Cohen Foundation for supporting such an incredible meeting of scientific minds and bringing those scientific minds together with physicians and patients and advocacy groups. I think it's really a laudable thing to do in terms of getting us all in one place talking together. And I'm very appreciative of the opportunity to moderate this international panel on Lyme disease impacts on global health. And with that, I want to start with a very quick introduction to the problem as we see on this map here. This is a global distribution of Lyme borreliosis, and the intensities of colors may be a little different from what you're used to because, in fact, this is not a global distribution of human Lyme borreliosis cases. This is actually a distribution of Lyme disease as reported by veterinarians, and this is a companion animal based distribution map. And the reason I chose this is to make the very important point that you have a generally good sense of the incidence of Lyme disease and other tick-borne diseases in endemic or certainly highly endemic areas for tick-borne diseases. In areas that are non-endemic, these areas where you have a smoldering presence of tick-borne diseases, the patient population is not where we should be looking to get a sense of whether tick-borne diseases are clear and present danger or not. We really have to look at the animal population, our domestic animals and our pets, our cats and dogs. If we look in the United States, obviously the distribution of the incidence of Lyme and other tick-borne diseases tracks very closely with the distribution of both Ixodes scapularis, particularly on the eastern seaboard into the center of the country, and then Ixodes pacificus on the west coast. And then looking at the distribution of Ixodes ricinus ticks, which is the primary vector for many tick-borne diseases in Europe, you see that there's quite a density of this species of tick, along with other tick species as well, not only in the European countries, but in countries bordering Europe as well. And then another area of the world where is not just a smoldering increase of Lyme and other tick-borne diseases, but I think a bona fide bonfire, if you will, in a part of the world that we don't typically think about, and that's in China. And so China is seeing a significant increase not only in Lyme disease, but in other tick-borne diseases as well. And that's perhaps not surprising given the geographic distribution of a wide number of tick species across the country. And the one you're probably most familiar with or have recently heard the most about is the Haemaphysalis longicornis, or the Asian longhorned tick. And the reason we're hearing about it here in the United States is because that is a recent tick species transplant to the U.S., and there have been a number of sightings of this particular tick in the Northeast. Its range is expanding. Thankfully, at this point in time, as far as I'm aware, there are no cases of Asian longhorn encephalitis, which is one of the principal human pathogens maintained in this tick species in China. But that could very well change the longer the period of time that longicornis remains here in the United States. Another important point to make, again focusing on China, is the very strong relationship between tick occurrence across China and how that maps with the diversity of climate zones. There are a number of different tick species across China, and they have their sort of favorite climate zones that they like to reside in. One other important point to make with this map is that the vast majority of Lyme disease cases which are significantly increasing year over year, are occurring in northern China, particularly northeastern China, and not surprisingly, that is the more forested area of the country. The other important point to make regarding climate zones is the fact that we now have a much greater appreciation of the impact of climate change on the distribution of ticks and, by extension, the geographic expansion of Lyme disease and other tick-borne diseases into the human population. And so with that, I will queue up our discussion panelists. As Savi mentioned, Dr. Jacques Lambert and Dr. Christian Perrone have video recorded their presentations. Unfortunately, they weren't able to be here today. So if we can have that first video clip from Dr. Lambert.
Yeah. Hi, my name is Dr. Jacques Lambert, and I'm an infectious disease specialist located in Dublin, Ireland. I've trained in America a number of years ago, so I was aware of Lyme, but actually, upon my arrival in Dublin in 2005, Lyme was really not on my radar screen. My expertise is more in the area of HIV, hepatitis, tuberculosis, tropical medicine, and the like. However, about 6 or 7 years ago, I started being referred in patients in Ireland who had these negative antibody tests for Lyme, but had a clear exposure for Lyme, and I've developed an interest and an expertise in that area. The challenges in Ireland are the same as anywhere else. I'm probably the only infectious disease specialist who has taken an interest in Lyme as a complex disease, with the standard approach being the IDSA approach of most of the European infectious disease doctors, who say it's easy to diagnose, their tests are 100%, and 3 weeks of antibiotics and you're cured, and if you're still sick, it's post-treatment Lyme disease syndrome, implying no longer having any infection. I've got a large cohort of patients I'm following at the present time, and the best strategy I've been able to find in Ireland to sort of move the issues of tick-borne infections beyond the narrow IDSA view, which most of my infectious disease colleagues have, is actually using the One Health initiative. So I've been working with University College Dublin Veterinary Medicine School. They have an interest in tick-borne infections. The ticks in Ireland have Anaplasma, rickettsial infection, they have Borrelia, and they have Babesia, and many of the animals are infected. I'm using that strategy to raise the awareness, because we seem much more aware of tick-borne infections in animals and veterinary populations than we do in human populations. So my plan moving forward is to do better studies in animals, better studies in ticks, better studies in humans, to look at the burden of tick-borne diseases and looking at the manifestations of diseases in these populations, and then eventually we'll move down to better diagnostics and better strategies for treatment. So it's a long battle, like it is in any other country with tick-borne infections, but I think the One Health approach, linking tick-borne infections globally in human and animal populations, is a strategy that I think will win the day.
And then the next presentation is going to be by Dr. Christian Perrone.
Dear colleagues, dear friends, this is a message from France, where we have also a lot of cases of Lyme disease, but now we have big debates in the media and the support of more and more politicians. So I'm Professor Christian Perrone, Professor in Infectious and Tropical Diseases, Chief of a hospital department in a university hospital near Paris. And I'm taking care of Lyme patients since 1994, so it's now nearly 25 years now. I realized at that time that many patients had negative serology despite the disease, and many patients experienced relapses despite 3-week antibiotic treatment. So now for decades the situation is not really improved in the world, and we have big challenges. One of these challenges is a need of a new diagnostic test, reliable test. And for example, we should develop new generation PCRs with better sensitivity to detect not only Borrelia but also other co-infections with bacteria or different parasites such as Babesia. We need also a well-designed randomized trial with a sufficient duration of treatment longer than 4 months, because all the trials published now, the randomized trials, are too short to conclude, and there is not a single trial in the world done properly. We have to face now a dramatic increase of the disease worldwide, and especially in North America and in Europe, and we need an official international recognition of the chronicity of the disease, because now we know that Borrelia persists in the tissues despite the treatments. And we need today to rely on clinical data waiting for the future good diagnostic test. So the situation is very complicated in many countries, but we can be excited by what we see in the medical literature with regular publications of good articles confirming the persistence of Borrelia despite antibiotic treatments, showing that Borrelia may induce immunosuppression, and also more articles about associated infections, hidden infection with parasites or bacteria or viruses probably, which I call now crypto infections.
Okay. Thank you for the organizer. My name is Fabrizio Bonelli. Sorry for the voice. I had the flu last week, actually this week. And today I've been asked by the organizer, especially Team Sellati, to describe which is the status, an overview of the Lyme disease in Italy. And also, since I'm the chief scientific officer of the private company, the Assori, I will explain and present which is our diagnostic approach, a novel diagnostic approach for Lyme. So, first of all, I've been contacting few experts also in Italy. And unfortunately, this is not a reportable disease. So from the epidemiological standpoint, the data are scarce and not very accurate. From what we know, the first case of Lyme was in Genova in 1983. And a recent survey done in 2014, as well as a report of the Ministero della Sanità in 2000, is telling that the number of cases is really limited, with the major region is that indicated in the circle, which is the northeast of Italy, close to the border to Austria and Slovenia. And in fact, right now, as we speak, we are carrying out our clinical study in collaboration with Dr. Ruscio, who is managing, is working since 30 years on the tick-borne diseases, and is working at the hospital in Trieste, again, close to the border with Slovenia, which is the area with the highest epidemiology. Nevertheless, in 2014, there was a paper published on zoonosis and public health that is reporting that ticks do exist also in other parts of Italy. And especially in an area which is close to, is in northeast, close to Lago Maggiore, the Ossola Valley. And also in the same area, there were the tick with Borrelia, and then also a handful of cases. So therefore, this may confirm that really is underrepresented, the Lyme disease in Italy. And also this information may introduce a better management and awareness of the burden of the problem, not just in Italy, but even in, not just in the northeast, but all the region of Italy, even the southern Italy, for instance, Abruzzo could be another region of interest, that is a little bit like this morning has been mentioned, the southeast of United States. Actually, this concept has been corroborated more recently in a paper published in 2018 that was with a study that was both spatiotemporal and environmental risk. Basically, what they did, they took all the cases, notified cases from 2000 to 2015, and what they saw that in the period 2018 and 2015, the risk of the number of cases was much higher as compared to the overall period taken into exam. And also from the environmental standpoint, they saw that the conditions that there are right now in Lombardia are favoring the development of the Ixodes ricinus. I think the same was probably for Germany. And eventually, these ticks are infected with Borrelia, burgdorferi, and Sellati. So this is important because here what we need is also in Italy, we need to develop standardized, accurate method, making sure that we are able to identify in a better fashion the Lyme disease cases. So who we are, just in the introduction, we are in a group that is international with many different R&D teams throughout the world. And recently we had we signed a collaboration with QIAGEN. And basically what we did, we developed a test for the detection of quantiferon for TB with a previous product that was developed by QIAGEN. And this accomplishment was really able to make sure that with our instrument, in our system, we are capable to do both, to detect both humoral immunity and cell-mediated immunity in the same instrument. And so, therefore, from this standpoint, we believe that we have a very good method to put together, to combine CMI, so the cell immunity with the serology, and then we'll offer advantages for the laboratory from one standpoint, the physician, and ultimately the patient. And we thought to apply this concept to the Lyme disease. Let me say that as a company, we are not new to the field. Actually, together with the group of the Maximum Pentecofer, here that at the time was represented by Volker, we developed a serological assay for the two serological assays for IgG and IgM. And also in collaboration with Volker, we were the first company to incorporate the VLC antigen in a serological assay. And also a few years later, we also had the FDA clearance for the first automated total IgG assay, which was incorporating the VLC from the Borrelia, burgdorferi, sensu stricto. We have discussed and we learned this morning which are the limit of the current two-tier, and so I will just mention a bit. But at the end of the day, what we understood, also talking to a few experts here in US, we put together a scientific advisory board, that there was a consensus that the basic unmet needs are three. One, to improve the early diagnosis in the window from, as also this morning was discussed by the team of the Geisinger, so improve early diagnosis to make sure that eventually there is an early treatment. The ability to monitor antibiotic therapy is another important point. And also, since one the IgG is there, you have to find a method to see whether this IgG is suggestive of a previous infection or is associated to a recent infection. So in terms of concept, then basically we know that omics technology are really identified the important role of inflammation and T-cell immunity associated to the acute Lyme disease. And there are metabolomics, transcriptomics, few studies are being produced. And however, none of these methods, particularly for instance metabolomics, can be still used in the prime time in the lab because of the lack of standardization. At the same time, Callister et al. And Professor Dattweiler a few years ago, they showed that combining serology to interferon gamma, they were able to get a very good sensitivity, up to 86%, without compromising specificity. And so that was a demonstration that IGRA can complement serology, and IGRA also at the same time is more robust in terms of priming time on standardization to other techniques, including all the omics. Also in the same paper, they were showing, talking about antibiotic treatment, that there was a decay over time of some patients. Actually, overall 69% of the patients were positive with IGRA, and following the antibiotic treatment, only 4 out of the 20 were still high or above the cutoff. And in contrast, the same set of patients were positive for anti-C6 antibody. 17 out of 29 were positive, so 59% of the patient. So therefore, the IGRA may be used as a test of cure, and also our instrument is structurally a platform to do a quantitation. So therefore, if you need to monitor, then you have the possibility with the instrument to do it. So where we stand, we put together a clinical study in Italy and Germany. In Italy, in Trieste, and in Germany, in Heidelberg. And the study is basically with collection of the patient at baseline when there is the erythema migrans, and we will follow for 15 days, 30 days, 2 months, and 6 months. And the idea is to validate this measurement in combination with IgG and IgM. And so in this way, basically in one session, we can classify all the patients with be recent or past, except when we have the case of IgG only, where this IgG only can be either past or recent. So to do that, what we thought is to introduce an avidity test for the G, which was intended to exclude or confirm a recent infection by identifying low and high avidity. So also from the system standpoint, our instrument has a software capability to flag the IgG-only sample, then can be automatically reflex to do the avidity testing on the same day, because we understood the time is a key factor. Right now, we understood in the US with the standard 2-tier testing, basically the sample will be sent to a reflex with the Western blot, and this may take 4 or 5 days. And again, this is against being as fast as possible. So in conclusion, we will complete the study, the first part of the study at the end of the year. Actually, there will be an extension for the 6 months. We are enrolling, as we speak, still patients in Trieste. But the idea is that if this works for early diagnosis, we probably will be able to improve the so-called 50%, so the coin concept that was discussed before, up to 80% without compromising specificity. For antibiotic monitoring, and to make sure that antibiotic that I learned today, sometimes they don't work, will produce a tool to assess the therapeutic efficacy. And also, finally, with the avidity, we will be able to have a tool to discriminate between past and recent infection. Thank you.
Yeah, thank you for inviting me to this interesting conference. First of all, your numbers from Germany are around 35,000 new infections per year, according to the reporting system. Around 80 to 100,000, according to prospective population-based study, and up to 250,000, 15,000 when you use health insurance data. So somewhere in between. Yeah, some examples on what we are doing in the National Reference Center. A major focus of our work is to give guiding to patients, guiding to practitioners, guiding to specialists regarding their diagnostics, therapeutics. This is around 20 hours per week for a professional. We do press releases, we do interviews, we are on TV, and we do scientific contributions. We organize symposia, up to 9 per year, with up to 200 participants. I think that's an important task, what we are doing there. One important situation which we are asked to do is development of a neuroborreliosis network. So for Germany, so far, this network includes neurological centers, universities, laboratories. Aim is to investigate incidence, clinical symptoms, course of disease, reactivity to therapy, and by follow-up, the outcome of Lyme disease, how this presents today in Germany. Just an example for our data bank in the internet, I think that's very important. That took really a long time to get something like that accepted from the Ethic Commission. The doctor can put any data from his patient in there, and very sensitive down here, polyradiculopathia, where it is, how long it is, when it starts, and so on. And this is all for the follow-up. So far we have 102 patients enrolled. I think now it's 108 with neuroborreliosis. The biomaterials that are remnants from diagnostics, they are conserved. And moreover, we have retrospectively identified 240 patients, of whom already 12 were included in clinical visits to get their data for future work. Then we developed a lot of special routine diagnostics, fine typing of pathogens, and so on. This is one of the results, description of new Borrelia burgdorferi species. And we found Borrelia miyamotoi disease in an immunocompromised person. Of note, as you can see here, in the red, we could retrospectively identify Borrelia in CSF by acridine orange staining. And what was also important, that this patient, as in Lyme, he produced valuable amount of CXCL13 in the CSF. This is a B-cell attractant, which is useful for diagnosis, for confirming diagnosis of early, maybe also of late neuroborreliosis. We found a new tick-borne relapsing fever species called Candidatus Borrelia kalaharica, called so because both patients published so far were from or acquired their infection in the Kalahari Desert. Actually, it was confirmed in some ticks from Sue O'Connell's group in the other side of Africa in a very aggressive tick. So I'm surprised that we are the only ones so far who found this Borrelia in travelers. We have, let's say, solved a small endemic, endemic of louse-borne relapsing fever caused by Borrelia recurrentis. It's the refugee crisis in Germany in 2015. We had overall 42 cases. Out of 15, we could cultivate the organism. That's, I think, very, very good result. And just to show that, it's all of those patients were very severe ill. A lot of them need intensive care unit, and one even died despite intensive care unit treatment. So this is a real severe disease. This is Borrelia recurrentis in the blood of an infected patient. You see left-sided, this is erythrocytes, a lot of erythrocytes, small, around 7.5 micrometer in diameter. And there is a whole bunch of Borrelia swimming in the serum of the patient.
It's amazing.
Yeah, this was. It was near near any of those patients you could watch the Borrelia like that.
That's amazing.
Yeah. So then we asked the question how those guys reach Germany, how that happens. They were all from Eastern Africa, Horn of Africa, and they were sent out in part by their clans, giving money to feed their families from Germany. They end up in Sudan. They were put into camps, and from those camps they can travel to Libya. There were a lot of different clans in Libya. They care for the patients. That means they robbed them. They put them in concentration camps under unbelievable hygienic conditions. One of those guys, a 16-year-old boy with a double-sided facial palsy because of Borrelia recurrentis, he told me, yes, in the morning when he gets up, he takes his hands and put all the soft ticks away from his arms. It was unbelievable hygienic conditions. They have to work for their travel to Europe, and if they worked enough, that may take some years, then they were allowed to travel over the Mediterranean. Thousands of them died there. Till now, sometimes because of Italy.
Not anymore.
And the Italians then put it into a train, and most of them were sent to Germany. So several questions arise from this situation. The infection, they could not have brought it from East Africa. There must have been some foci either in Libya or in Italy. We did not find them. Another question, why only people from East Africa were infected? They traveled with other people. None of them was infected. And lastly, what happened to the transporters that transported them from Somalia, from Eritrea to the north? Maybe most of them died on the way. We did some sequencing now on these Borrelia. There were 2 historical strains. You see those bulks. This is the chromosome, and the brown rectangles, they are SNPs. They are regions with differences, and the blue circles, they mark regions where you can differentiate between historic and actual strains. And we were not able, until that time, we were not able to distinguish those strains. They were looking like clones with MLST, with IGS sequencing, with things like that. So we looked more into that, and this is the region where the intergenic space is located. So you see there is no difference between the strains, so we cannot differentiate them. The same is true for multi-spacer sequencing, and the same is true for multi-locus sequence typing. So now we want to develop some methods to look for the different regions more directly. We do a lot of epidemiological studies. I think the most important are the population representative children study, KIC study with 12,000 sera, DEC study with nearby 7,000 sera. Then there's an additional a bunch of sera with, actually we investigate with this more than 10,000 again. We looked into the seroprevalence. That means how many of the investigated sera contains IgG antibody against Borrelia. Here you see in red the seroprevalence of female, in blue of males. That starts nearby 0, and that ends up in 80 years old with around 25%. Risk factors, just to mention that, is living in southern Germany, and risk factor is living in small towns or on the countryside. For children, it's also owning a cat. Thank you.
So I think we'll have some time to field some questions. The first one are your tests universal or only focused on the European strains of Borrelia?
This for me? Well, we have the European version for GNM. We have the total IgG for US, and we have the representation of the European strain for Europe. And for US, we also had the census tract as well.
So usually the European tests you can also use for US patients. The US test you cannot use for
The vice
European
versa.
patients, maybe because of the much greater heterogeneity. So we have 5 different human pathogenic species in Europe. And they are even within one species, they might be very heterogeneous.
Okay, that's an excellent point to make, to draw out that distinction.
Mm-hmm.
The other question is, were actual ticks transported to Germany on the highway to heaven or just infected people?
Actually, it's only infected people. This is louse-borne, just to mention. This is, but this is an important question because actually we have a tick, Hyaloma marginatum. This is a real large tick, up to 2 centimeter, unfed. Wow. 2 centimeter, and that crawls quite quick. And this is not only like a spider. This can transmit the Crimean Congo hemorrhagic fever. This is a disease like Ebola. This is horrible. They die from that, and even in intensive care units, when the doctors infect themselves, and most of them, when they are infected, die of the disease.
Okay.
And the transporters for hyaloma is birds.
Right. Okay. So, how many bands on Western blot quality qualify as diagnostic by German diagnostic criteria?
2.
2.
Yes.
Okay.
So as a strong IgM OSPC is also diagnostically okay.
Okay.
Yeah.
Interesting. And then I guess the same question for the Italian diagnostic criteria.
Yeah, also I can confirm that we had actually we're using the OSPC, also in combination with the VLC as well.
Okay, all right. And then it says, as a Lyme patient, I hear a great deal about different treatment methods and efficacy in German clinics. What do you feel are the major differences in your protocol compared with the US?
We have, in principle, the same protocols as in the US. There are some so-called specialty clinics. They offer protocols that are never verified, that are never validated. They use substances, anything, a lot of different things, and we don't know. There are no studies, or the studies that were done did not show efficacy.
Okay. All right. And then what would you say? Would you say there is a lot of resistance to Lyme in Italy and Germany politically, or is sort of the political landscape the same as what we deal with here in the United States, or Canada deals with, or Australia deals with?
I think in Germany, it's in principle comparable to the US. There is for sure resistance, but what we are actually, let's say, learning is that communication is an important situation. We have to discuss. We have to go into the subject. We have to look differentially on what we are doing, what is necessary, what is needed.
Okay.
I would say the same for Italy.
Okay.
So it's mainly a matter of awareness.
Right, awareness. Okay.
Yeah, and the awareness is
Right.
becoming bigger, but the mosquitoes are a big against.
Okay.
So they
Interesting.
got a lot of money in Germany actually
Ah, I
to
see.
do research on mosquitoes. We have invasion of tiger mosquitoes. We have invasion of Aedes aegypti. We have invasion of japonica.
Okay. So that's seen as perhaps a more pressing vector-borne infectious disease public health
This is something
issue than ticks.
that goes very fast. So you have your focus on infection, and then within 1 year you have huge regions infected.
Okay. All right. Well, thank you very much for enlightening talks.